I think you can palpate bony structures a little bit better to figure out where you're at in terms of getting intra-articulars. What?
Tell me he dumps it.
No. But he was gonna, like, I was gonna help him move the other things out of the way so he could pull the bear. He's like, oh no, I just take the bag. Just grabs the bag out, and I'm like, how are you just like, and it's like just a garbage bag in there. I'm just like, don't you want it to stay in the hard protective thing so nothing stabs you? Yeah. I was like,
it's a garbage bag he pulled out?
Basically a garbage bag.
You're like, you're the boss.
I'm like, yeah. Like, the moment you touch it, I've signed the liability over to you.
Yeah.
So,
that man has no fears.
No. He doesn't even wear gloves when he like changes out all this stuff.
He has death wish.
So my theory is that he actually already has everything that you can get from bloodborne.
He's got like Hep C, HIV. He's good.
So he's just like the renegade.
I wonder how he got
I only got 3 years left. I'm gonna make sure they count.
Keep stress low at least.
All right, so we got 13 minutes for questions because then we got 40 minutes of demo today for shoulder. So what do you guys got?
Coracobrachialis.
What about it?
Do you ever treat it? Do you ever see that it's injured?
I think I've treated it maybe 2 or 3 times. It is, I think, less frequently injured than like your slap tear, right? Your bicipital involvement into the labrum. But the main indications that I see for coracobrachialis is we have a similar presentation for a bicipital tendinosis.
Right.
But when we do our standard biceps testing, it doesn't really come up as positive. But then when you basically do a bent arm 90-90 and you test more coracobrachialis and you can get a little ER with it as well, then that's when you see some weakness and or pain, and we can treat it then.
For testing it,
You tried.
it's adduction with shoulder flexion.
And you'll have a little bit of external rotation as well, because that's going to make that in more of a straight plane.
So that's why you go down.
Right, as opposed to being in here, when you do a little bit of external rotation, you're going to test it a little bit more.
So you keep the elbow in when you do that?
Yeah.
Okay. What about subclavian? Do you ever see any pathology with that?
I haven't seen a lot of pathology with it, so I've never treated it.
Yeah.
No.
Just doing anatomy review.
Very tight. They're very tender though.
Very tender.
Yeah.
Which is, I was palpating it myself as I was.
I don't think so.
It's not a major muscle mover.
Exactly.
Right.
So
So if you start getting into, has anyone read Anatomy Trains? You all should read Anatomy Trains, and there's actually a new version coming out in May. Did you know that? Yeah, I pre-ordered it. I'm stoked. So I definitely recommend you guys should read that book, because what it talks about is fascial meridians in the body. So how, for example, the sacrotuberous ligament is fascially connected to biceps femoris, and so when you have alterations in biceps, or if someone keeps chronically getting hamstring tears and things like that in biceps femoris, how actually going up and addressing the other structures that are fascially connected can have an impact. And so I incorporate that in with my assessment and how things are functioning in patients. But so one of the things that he talks about is that there's some muscle groups based on their location and fascial connections that are more likely to be under strain, and ones that are more likely to become hypertonic. And so I think subclavius is probably one of the ones more where it's less likely to be in a degenerative state that we think of with, like, lateral epicondylosis or patellar tendinosis, and more so likely to get into an over. It's like traps. Like the traps, generally, you're not finding degenerative condition in the traps, the hypertonicity,
right,
because it's compensating for other things. And so I have a feeling subclavius kind of falls into that camp.
How do you use the screening for fascial meridians, and how do you use that? Is it based on how they're walking in? You can kind of do a gait analysis, posture,
A little bit.
or is it very specific?
It's I generally use it more specifically. So I'll watch gait patterns. I don't do okay, let's get out and let's walk, but just how are they moving? How are they sitting? When they're talking, you know, what position are they rotated in? How are they sitting in the chair? Those types of things. But then it really comes in with the orthopedic testing and things like that. And so what I will generally try to do, and this is still something that I'm kind of just playing with and trying to figure out, but a good example is I had a patient who had some SI pain that kind of didn't really fit like the classic mold of sacroiliitis, but I also knew that she had she had right SI pain and left shoulder pain, and so there's the that back line that's going to cross over from the hip to the shoulder. And so when we were doing straight leg raise, it was at like 75, 80 degrees, and she was starting to feel that tension in the low back. And so to see if that fascial plane was involved at all, what I had her do was then I had her take her left hand and bring it over to her right hip to tension that fascial line and then retest to see what happened. And she started getting her back pain out around like 55, 60 degrees. So then that to me is like, okay, I know that I can go and treat SI and get benefit, but long term we need to do something about this shoulder as well, because that fascial connection is dysfunctional or it's impacting it to some degree, that treating both would be beneficial. So that's kind of how I incorporate that. And then just with like our big direct connections like IT band onto tib anterior, right? If someone's got shin splints that are lateralizing onto the outside as opposed to the inside, and we know maybe tib anterior might be involved a bit, how's IT? And so it's looking at those connections as well.
And then if you were to address the shoulder, the fascial connections of the shoulder, what would you do? Would it be gua sha? Would it be cupping? Would it be fascial work manually?
Generally, I'll just do PRP in the area as well. And so with that comes, there's a doc out of Austin, Texas. His name's Brad Fullerton, who actually was the one who introduced me to incorporating the fascial meridians in with the injections. And so what we do is we do basically sonopalpation, and we're looking for where we have basically increased compressibility of tissue planes. So if you have, and maybe we'll look at it in ultrasound today, but if you have a tissue that is not degenerative, when you compress it, right, it's going to maintain its physical properties. So when you compress, it's going to have some bounce back to it, and it's not going to collapse on itself. When you have tissues, and we see this a lot with infraspinatus, but when you compress those tissues, what you'll see is and it's generally usually the deepest layer, is it will kind of compress as opposed to, it will collapse as opposed to compressing. So it doesn't maintain its tension. Back. Yeah. And so we'll treat those areas with PRP, because his theory is that's where you have this loss of tissue integrity that's resulting in a weaker fascial sling that then is contributing to other areas. So my guess would be gua sha and things like that could be of benefit as well. I just haven't explored that because.
So where do you put the PRP? Is it intramuscular in that case, or is it?
Yeah. Cool. And then so generally I'm actually going to use PPP.
Okay.
In the past I would have used PRP, but this past year enough research has come out showing that when we use PRP intramuscularly, we're actually causing increased fibrosis, and long term that can actually cause issues. And so I've switched all my intramuscular injections over to PPP.
Okay.
Yeah.
What about like an amino acids or a peptide instead of a PPP? Like a vitamin C or something like a collagen-based precursor?
Oh, like just orally?
Or in addition to injection?
I mean, I think PPP works well enough, and if we're already in there for PRP, I don't think it's...
Yeah, if you have a solution.
Yeah. And I don't think... I think, you know, and I know we've talked about this in past weeks with using like vitamin C and with injections, but I think that's the only time I would use that is to try and protect cartilage from the chondrotoxicity of lidocaine or ropivacaine or whatever we're using. So, so I don't think I'd use vitamin C for something like that.
Bethel mentioned yesterday in the regenerative selective class about 3 main steroids. Can you kind of, and I don't remember, one was methylprednisone, one was something, and I don't remember.
Triamcinolone.
Do you remember what the third one
Which is
was?
Kenalog.
Dexa.
He said Depomedrol, but that's
Depomedrol is methylprednisolone.
right.
Dexa.
I can't remember.
And then Decadron is dexamethasone.
Oh, maybe it was Decadron.
Yeah.
That must have been it.
So, yeah. So, I'll give. I rarely use Kenalog, and so I'll give you the differences between the Depomedrol and the dexamethasone, and the biggest things for me that I care about is that the dexamethasone is a non-particulate steroid and the depomedrol is a particulate. So if you actually look at the vials, dexamethasone or Decadron is clear and you can see right through it, whereas depomedrol, like it's milky, right? It has actual substance to it. And so that's important because if you're doing any form of epidurals, so whether you're doing a caudal epidural or a cervical epidural or transforaminal, you do not want particulate matter to be in the epidural space. And so you would not ever use methylprednisolone or the depomedrol in an epidural. You would use dexamethasone. And so, and I know there's different properties on how long they last and all that kind of stuff, but I don't do, I mean, I've only done, in residency I used a lot of steroid because it was insurance based. But outside in my private practice, I think I've used steroids once in the past 2 years, just because when a patient is presented with a steroid injection and PRP for the same price because I'm cash pay, they'll choose PRP over steroid. But those are the big things that you want to know if you're ever going to do epidurals.
You said the methylprednisolone was the particulate one, and then
Correct.
dexamethasone is
Non-particulate, yeah.
Okay.
Yeah. The main things that you're going to want to be palpating on our shoulder is obviously going to be our clavicle. So let's get back. Relax. So palpate in the supraclavicular fossa, getting closer, guys. Supraclavicular fossa. Okay, you can palpate out superior border of clavicle, and you can palpate out inferior border of clavicle. Okay, that clavicle is going to connect with our acromion for our AC joint.
Osteoblastic production after Olympic lifting.
So here's our AC joint, okay? So we have the distal end of the clavicle and then the proximal end of the acromion. So I'll have all of you guys palpate as well. Remember that acromion then wraps down on its distal lateral aspect to become the spine of the scapula, right? So then you can palpate the spine of the scapula. Okay? So you can also palpate over from the clavicle, and you can palpate your sternoclavicular joint, which is right here. Okay? Obviously our larger muscular landmarks we can see, and it's nice when you have someone who's actually muscular because it makes it much easier to see the borders. But we have our anterior deltoid, right, that's running down. We have our middle deltoid and our posterior deltoid. Okay, so marking those off. So if you were to be evaluating for any deltoid insertional tendinopathy, which is pretty rare, but seen it a handful of times, you're going to be down in here. These are anterior, and then our posterior, which we will use as a landmark for what structure?
Quadrangular space.
Not quite. Yes, we do, but there's one more that's specific. The superior lateral brachial cutaneous nerve. that's piercing through the superficial fascia and about this region here, then wrapping over the lateral aspect of the shoulder. Okay. So from here, let's go into a. So remember, you're going to want to be in a neutral position, or a supine, because this is going to be neutral. A supine position, which is going to help take that biceps and move it more anteriorly. Because if you watch biceps, right, this is our bulk of biceps, which is then going to come up and form our tendon. When you go into internal rotation, what happens is that whole humerus rotates, and I'll show you on the ultrasound after, but it's really, really hard to see where the bicipital groove is and the biceps tendon when we're in this internally rotated position, which actually helps to bring out what structure for our injections?
Super.
Yeah, our supra and infra enthesis on the greater tuberosity, right? Because they were rolling and taking what was lateral and moving it a bit more anterior, so it becomes a little bit easier to palpate. So from here, you can do your Lippmann's test to find our
Bicipital tendon.
right, and his is nice and large, which is always good. So, right in here is our biceps tendon, okay? So then, from there, you'd be able to feel that. You could move this into an externally rotated position, and you feel it move over here, so for you to find your subscapularis enthesis on the lesser tuberosity, and then come internal, and we can find the bony attachment of supraspinatus and infraspinatus. Okay. Our supraspinatus, remember, is running deep to the trap here. It's going to run underneath the acromion, and then it's going to come out and attach onto basically this portion here. And so from this position, basically this bony structure in this region here is roughly where our supraspinatus is going to insert. And then infraspinatus is actually, a lot of people think it's inferior. It's actually posterior and slightly inferior. And so this here is our infra or supra, and then our infra is going to kind of be in this region here. Because these two are going to blend together with infra attaching kind of first and then supra attaching afterwards. Do you have a question?
Can you put an S and an I? Nice.
And then when we go into our externally rotated position,
Ding, ding, ding.
infraspinatus. Or sorry, subscapularis.
Tender.
But now they all go on to form the rotator cuff. Is that right?
Correct.
Okay.
Yeah.
So they have like individual attachments, but they're all attaching onto the rotator cuff, which goes on to encompass.
So no. So rotator cuff is just a term to describe the four sits muscles, subscap, infra, teres, and supra, that control rotation of the arm. So they don't insert onto the rotator cuff. The rotator cuff is just a term for all four muscles. So the supra and infra fascially blend together. Teres does not. Teres is separate, and then subscap is separate but actually still attached. And I'll show you, subscap actually crosses over the bicipital groove and has a fascial attachment onto the greater tubercle.
Darn YouTube video. They're saying they all blend kind of into the same fascial or tendinous sheath. Is what they're...
Well, kind of, yes, and that's more so with supra and infra.
Yeah.
But teres not really.
Okay.
And then again, subscap is on its main attachment is on a completely different part of the bone, right?
Yeah.
Because that one's coming from the anterior aspect of the scapula inserting onto the lesser
That's- yeah.
tuberosity versus the supra and infra coming from the posterior aspect of the scapula and inserting laterally on the greater tuberosity.
So Terry's major would be in here somewhere, onto like,
Yep.
and then minor would be like
Mine would be back in here.
back in here, right?
Yeah, and we can scan and show you that.
They'd be inferior to where we are currently. Like they'd be lower.
Definitely.
Yeah. For accessing the joint, I take a posterior approach when under ultrasound, and I take an anterior approach when doing palpation based. And that's just because I think you can palpate bony structures a little bit better to figure out where you're at in terms of getting intra-articular. So, what are 3?
Coracoid.
Yeah.
Acromion.
Which coracoid? It's right here. Okay, coracoid, acromion,
Anterior part of the acromion.
and then we're also,
The most prominent part of the humerus. Well, I guess that would
which
be.
again, a lot of people come in like this. It's just this. You're doing this to feel where's the most prominent portion. So here, here, here. You're gonna triangulate. You're gonna find the middle. Right there, which again is always going to be superior to where supra and infra insert, because supra and infra insert outside of the joint capsule. So you can't access the joint capsule if you're going through supra and infra. So will be superior to that.
Is Zach's musculature making it so that it's more superior than what it would be for others? Is deltoid, because isn't for other many others more
I don't think so.
anterior? No, it's
Mm-mm.
pretty typical.
And then from now, you'll slightly have to adjust with more muscular, because it's if you have like the actual humerus here, the musculature could be built out more anteriorly and anterolaterally than laterally and posterior, and so it will change slightly, but it's not going to be like a huge like over 3 inches different or anything like that. So then from here we can insert. In which direction do we generally want to insert?
Lateral.
We usually want to come this way. The reason for that, you can go this way. I like going this way because generally I know if I'm out this way and I hit bone and I inject and I'm not in the space, I know that I have to go medial, right? And I can continue to walk until until the needle gets inside the joint capsule without really risking damaging the labrum, okay? If you come this way, the labrum is situated in that plane. And so your first pass needle could go all the way, and you could just be gummy, and be going through the labrum the whole time, okay? The labrum's a not very well vascularized structure, which makes it more difficult to heal.
If you, you'd have to be really far off to come to the lung, right?
You have to be very, very far off. Yeah. Because again, remember, lung, so we have to have our ribs, which are all the way over here. Well, they're going to come up this way. But if you're coming from top, it's a bit more.
Because apex is right there. So.
Yeah, apex is going to be here. But when you're coming anteriorly here, you'd have to be very, very far off to.
You go through a lot of good stuff to get
Yeah.
there.
Yeah.
You have to go through a lot of good stuff.
Miss the ribs.
You'd have to go between ribs.
Yeah.
And what about the bursa? Because doesn't the bursa lay in between?
Yeah, so the subacromial subdeltoid bursa is basically going to run in this plane here, and it's going to be deep to the acromion, and it's going to lie in between your supraspinatus and your deltoid.
Okay.
So that's why it's called the subacromial subdeltoid bursa, the SASD. Yeah, and I'll show you that where that would be under ultrasound.
But so when doing the shoulder joint, not so much of a concern because it's more lateral, more superior than where we're going to be going. Or if you
well, technically, when you are injecting the enthesis of supra, you need to pass through the bursa to get there. Yeah, but it's not a major issue if you put a little bit of fluid inside of it.
a bursa.
Yeah. Okay. Any questions? Yeah.
Tendon injection enthesis is through here.
Yeah, so our long head of biceps attaches where?
The labrum.
Right, and it attaches onto the labrum on the anterior aspect, the anterior superior aspect of the labrum, okay? So one of the ways that you can attempt to get close to that is this is without ultrasound guidance, is by coming through what's called the V. So your acromion has this little V shape in here that you can feel when you're coming along trap, and obviously deep to trap is supra, and you will come up to a spot where this is the internal hook of the acromion, okay? That can give you access because from here you can go inferior and you can drop down either onto the glenoid rim or the head of the humerus. And so with the injection or the needle, once you advance the needle and hit bone, what you can do is you can take the patient's arm and you can passively do IR and ER. Because if you're on the head of the humerus, what you'll see your needle do will be huge movements, right? Because the needle is on top of the head of the humerus and the head of the humerus is rotating. If the needle is on the glenoid rim, which is what we want, you'll still see a little bit of movement because the needle is passing through supra, and when you do this, supra elongates and shortens passively. You'll still see a little bit of movement, but it won't be big movement, okay? And so from there, you know that you're on the glenoid rim, and then you can walk it anteriorly as you do injections to basically try and treat the insertion of the labrum onto the glenoid rim. And by doing that, you will hopefully hit the insertion of the biceps tendon on the labrum, which would be our slat tear. Good?
So that's another access point to an intra-articular if you had to.
Yeah. Yep, because if you come here and you get onto the head of the humerus, you'd be intra-articular. I don't like doing that because then your needle hits cartilage and that can damage cartilage, obviously. And then just one more thing for the body to have to heal in that process. Okay?
And what nerve trajectories, Dr. Timmermans, that we have to be mindful for? I know we're dealing with the...
On the anterior shoulder, not much.
Not much, okay.
No, because your brachial plexus is going to be super, super deep and midline to the humerus, and so we're not really getting into that area. The brachial plexus up here is going to run underneath the clavicle, and so not a huge concern. If you start going into where you're now medial to coracoid process or anything like that, that's where it'd be a bit more concerning.
Okay. And this axillary nerve, it comes out underneath the deltoid and wraps around?
Sorry, say that again.
Axillary nerve? I know that comes out at quadrangular space.
Yep.
And then it wraps around underneath the deltoid?
Yeah, it wraps around the humerus.
Around the humerus, yeah, so very deep.
Yeah, very deep. But then the cutaneous branch that it gives off is the superior lateral brachial cutaneous nerve, which is the one that pierces through the fascia just posterior or inferior to the posterior deltoid. All right, so remember how do we start to identify our structures with the ultrasound? What's the first thing you want to look for?
Boney landmarks.
Boney landmarks, okay? So what you're going to be looking for is a sharp hyperechoic line with anechoic underneath, okay? This here is a really great example of an artifact. So imaging is never perfect. There are things that can create artifacts, which are basically they're fake, okay? They're not actually present. So this here is a type of reverberation artifact where basically what's happening is because this is very perpendicular to the sound beam and in the midline, what's happening is you're seeing a shadow or a reflection that is deep to a hard structure that is an artifact. There's no bony irregularity here, and the sound's not actually getting deeper than this. It's just an artifact of the image, okay? So we have bony structure here, and then we can look at several different layers, and you can start to kind of piece together what might be going on in this area, okay? This up here is the classic look of muscle. And we know that the first layer, when I'm here, the first layer that we have to go through is going to be what muscle? Deltoid. So we know that this is deltoid, okay? Then we start going deep. And at this location, we know that, okay, it's got to be deltoid, and then what underneath?
Infra?
Or
maybe
biceps is going to be way more over here.
Maybe super.
Either infra, supra, or kind of a combination of both of those because of the plane that we're looking at it in. Okay. So I generally start my scan over biceps tendon. Okay. If I go to the anterior aspect, you see how I can't really see a groove very well over the humerus. Go supinated for me.
Yeah. Oh,
Let me flip this.
is that right?
Oh yeah.
There's our biceps tendon, okay? And our biceps tendon has what I like to call a coin-like appearance, right? It's really shiny. And then we can follow that there inferiorly more into the groove. And you can actually see by my palpation, I was too medial on my palpation. And what I was likely then palpating.
Well, you had me out here when you palpated it.
Yeah, still too medial. And that would be a function of basically a fibrous, like a tighter fibrous band in his anterior deltoid that misled us all for his biceps tendon.
Could that be the coracobrachialis?
No, because over that spot it's all just deltoid. So there is our biceps tendon here, which you can then follow that in its groove superiorly, and then that can continue upwards, and actually as it continues to dive into the joint. So that's actually an intra-articular portion of biceps.
So it's just a fan out, right, as it's getting closer to the labrum.
It does a little bit, yeah. You can then continue that down. You can still see the biceps tendon there. Coin-like appearance. We continue to travel that down. And then you see, so watch right here, and then it'll move down this way. See the black line starting? That's the muscle. So that's the myotendinous junction. And then there we see biceps really starting to take full effect. Around the place where we have that myotendinous junction of biceps is you start to see pec major, right? So top pec major, pec major, coming over, and you can see it. What is the other spot there? Tendon. So here's the tendinous insertion of pec major. So if you're ever going to treat an insertional pec tear, that's where you'd be treating it. You can see that traveling over. And this is a great example of, remember how we talked about, I think it was last week or 2 weeks ago, how the tendon forms inside the muscle first. It's not like it just goes muscle, and then boom, tendon.
Mm-hmm.
So here's the intratendinate or intramuscular portion of the tendon that's forming that then continues to become tendinous before its insertion. Okay. So we got our bicipital tendon. Okay. We can also then flip it and we can look at it in long axis. So remember, this is short axis for the tendon. This is long axis for the tendon. So there we can see the length of the tendon, and again, you can continue to travel that up. Continuing, and you can see it then diving into the shoulder joint. So then from here, we can obviously go medial, and then we see that bony portion there is the what?
The groove, the occipital groove.
So this is the groove, right? Because that's where the tendon is. If I go just medial to the groove, what bony landmark do we have?
Subscap attachment.
Which is?
The last one.
Yeah. Okay. We go back to the groove, and we go just lateral. What do we have here? Greater. Okay. And so we can look and we can appreciate some cortical irregularities on the greater tubercle here. See those? How we're kind of losing the sharpness on the bone there, right in this region here. And we didn't really see that all that much on lesser. Lesser actually looks pretty good. Okay. So there are, when you start really getting into ultrasound, there are specific positions that you have patients in, specific planes that you're looking at muscles for evaluating, which is obviously really great to learn, but it's also important for you to be able to have the anatomical knowledge to just know that, okay, I'm here with biceps, and when I go lateral, I know that that has to be the insertion of supra and infra onto the greater tubercle of the humerus, and without it being in the exact plane that your the book might tell you to look. Okay. So let's come here to supra. So easiest way to find supra is first to palpate for where you have that V, because you know that the supra has to run underneath the acromion. Okay. A little bit more depth. So we have the top muscle here, which is going to be what? Trap. And then deep to that, we are going to have
Supra
at this position, right? If we were below the spine of the scapula, then we'd have trap and then infra. So we continue. Here is the acromion. Okay, so we want to be going past the acromion, and then what comes out on the other side is our beautiful bird's beak view. Okay. This is our greater tubercle, and this is our insertion here of supra. So that means all of this is supraspinatus. What do you think this right here is? This black spot?
Is that bursa?
Nope.
Cartilage.
Nope.
Artifact.
Yes.
Anisotropy.
Anisotropy. Well done, Alan.
You taught us well.
So remember that if we are not perpendicular to what we are looking at, we can not see something because the sound waves are not hitting. And so what happens is when I apply toe pressure, I can bring that back into view. So we can actually see it now because I've just changed the angle at which we're looking at it. See how it's dark? And then see how it lights back up.
It's an awesome separation of fibers here.
Yeah.
You can see the fluid in between.
So
Thanks for really going for that.
this here is the bursal fluid. This here is the inferior portion of the bursa. This is the superior portion of the bursa with bursal fluid in between. This is a normal physiological amount of fluid I wouldn't consider that pathological, but this is actually more than generally what you'll see, but it still falls within the range of normal. Okay? You also know that it's not a tear, because if we follow that line, do you see how it continues past our insertion of supra? See how it's continuing past? That's how you know it's the bursa. It's continuing past the insertion. If it was a tear, it would come down and it would insert onto the greater tubercle. Okay?
Are long axis, like that would be a long axis tear versus a short axis tear?
Well, so long axis and short, you would want to say longitudinal or horizontal if you're referring to tears.
Okay.
We don't use a long axis and
Yeah.
short axis really.
That makes sense.
That's more for imaging purposes.
Mm-hmm.
Okay? Can I get a bit more gel? Thanks. So there again is our insertion of supra and long axis. So if you want to, this is a really good way to learn what things look like in different planes, because it's super easy to find long axis. It is much more difficult to find short axis. I lost it there. All right, so here, and then we're going to rotate. So that there in the middle of the screen is your short axis of supraspinatus. See how that is a lot more difficult to see and make out what it is? And then you continue that down, and there's its distal insertion. And you travel it back up, and then you can see muscle, the tendon. Okay? So that's why it's good to learn specific positions for that, and then rotate to see what it looks like in different planes. So there's our supra. Now to find infra, you can take the same approach and just start inferior to the spine of the scapula. So again, you could actually find the spine of the scapula, which is in the middle of the screen there. See the little peak at the top?
Mm-hmm.
So then we know that inferior to that, we're going to have infraspinatus. And then here's infraspinatus starting the tendon. And then its insertion. So, pretty close with our palpation. You lost it, but pretty close on our palpation for infra. So if you end up coming to the shoulder and you look at something and you go, I don't know if that's supra or infra, follow it back. If you see the acromion and you see it diving underneath the acromion, you know it has to be supraspinatus, right? Because from here, see how that looks really, really similar?
Super similar.
That's infra. That's supra.
So go back to infra. Follow back. What's that black line there?
Here,
Yeah, is that just anesthetic?
that's muscle.
Okay,
Below that.
right there.
Oh, below it here, you mean?
Yeah, the kind of splitting between.
Like right there?
In this way?
Yeah.
Mm-hmm.
Oh, that's muscle tissue
Okay.
Yeah. of infra. Bring your arm across your body and hold there. So again, this is our, which one do you think this is?
Infra.
Infra, right? Because we don't see it going underneath the acromion. When you travel infra back, that's where you can find your axis. Find access to the posterior shoulder joint. Okay. So right here, that is the posterior glenoid rim. Here's the head of the humerus. Head of the humerus with the anechoic cartilage over top. Here's labrum extending out to capsule. There's a good picture there too.
So you'll see this blow up with fluid.
You actually won't see it blow up with fluid
'Cause
if
it
you're inside the
disperses.
joint. It will flow down and it won't balloon out, and that's one of the ways you know it's in the joint.
Even with like hydrodilation.
With hydrodilation, you will see some ballooning out towards the end of it, but it will follow the contour of this. Whereas if you're outside the joint, it will balloon up like this, and it won't follow the contour of the joint. Whereas when you're in it, it will follow that contour. Very good. So, glenoid rim, humerus, labrum here, and then capsule. So when you're doing this injection, you can either come from this way or this way, but the goal is you want to get, you basically want to get right about here. So you want to lay on top of the cartilage, but deep to the labrum. Okay? Alright, we got a few minutes here. Relax the arm back down. Let's look at your AC joint. AC joint is super, super easy to see.
Just a gap.
So your short axis of clavicle. See bone, see bone, see bone, see bone, see bone. See that drop off? That is the joint space, which in short axis, all you can really see is just this round void here. That's the joint capsule and the joint space, right? Because there's clavicle, joint space, acromion. Joint space, clavicle. So then we can turn and we can see clavicle, joint. Here's some of the capsule, it's a little swollen, and then acromion. Oh. So in your injection, you can do an out of plane approach like this, or you could flip it this way, find it there, and you can do an in plane approach. Either one will work. That's actually a good picture. There you can see the large joint space. Okay? That's kind of the bulk of the shoulder. The basic stuff. Any
Are we
questions?
able to see Terry's or no?
Oh, yeah. So let's start with so there's infra. And there's Terry's.
It looks just like infra.
Yeah. But it's more inferior.
Right.
So there's Terry's. There's infra.
Okay.
But you see how like that muscle just like looks all, and it's actually there's the transition where you kind of see that shininess going across it.
Mm-hmm.
That's the fascial plane, and then you're into Terry's.
Very
Yeah.
similar.
Yeah.
In insertion and origin.
teres, infra, supra.
Teres is a little bit more of the abduction.
Say that again.
Because they both do external rotation, but teres is a little bit more of the.
Yeah, because it sits lower down, so the leverage point is a little bit better. Yeah. Beautiful.